Hi, my name is Hasan Rizvi. I'm a consultant hematopathologist at Barts, and I'm going to be talking about cytochemical stains in hematology. So before we start, I'm just going to cover what the next 40 to 45 minutes will deal with. I'll just describe what cytochemical stains are, how we got to doing these stains in hematology, what are the particulars of each stain type, and then what are the uses in hematology. So before we get into any details about cytochemical stains, I just want to talk about how pathology practice and classification of disease has developed over the last couple of 100 years. So initially, if you look at papers like Thomas Hodgkin's landmark paper, which describes the lymphoma that he had, put together from a case series of patients. It was based purely on macroscopic and autopsy studies. Then obviously we come to the era of the microscope and morphological descriptions of disease based on cytomorphology or histology. In the 1960s, 70s, we start the development of electron microscopy, special stains, immunostains, and these held sway till sort of the next millennium. In 2000, we started using more and more genomics, and digital pathology is coming of age. So we're now entering an era where digital pathology and molecular are contributing to personalized medicine, where instead of using a generic treatment or a generic diagnostic standard for disease, you're fine-tuning it for each individual patient. And this is based mainly on data or informatics, and eventually all of this will then just be bits and bytes of data which we'll analyze. So we are now what people are describing to be the third revolution in pathology, which is the computational pathology, where based on data and informatics, you're getting personalized information both about diagnosis and treatment. So, and we're moving, if you look at the top of the screen, from what's called low value or process driven pathology to high value data driven, where you can, be much more accurate, be much more objective rather than subjective in your analysis, in diagnosis. So this obviously also has contributed to how we think about classification of disease. And when we think about cytochemical or morphological classification, we think about the French, American, British in hematology, the FAB classification, which came out in 1976 and which described M1 to M7 morphologies, which range from undifferentiated myeloid to erythroleukemia, monoblastic leukemia, and megakaryocytic leukemia. Then as we move forward, it became more and more genetics based, and now the current classification of leukemia is based on a lot of recurrent genetic abnormalities, on molecular data, and that's where we're heading. So this kind of ties in with the previous slides, where we're moving towards computational and genomic medicine. And this is what the current WHO, there's a new one coming out this year, but this is what the 2016/17 version looks like. It integrates findings from morphology, histology, and cytology both, then cytochemical stains, immunohistochemical stains, and then molecular testing like FISH and PCR, next generation sequencing or gene expression profiling is still something which has not made it to this current classification of WHO, and that's why it's in green on this gray in this screen. What usually happens, this is our setup at Barts. We are all co-located in one building, which is called the Pathology and Pharmacy building, where you have all the different disciplines. You have molecular pathology, flow cytometry, hematology, and histopathology all together. And the reporting of hematological malignancies as well as non-malignant heme has now become an integrated process where multiple different modalities like hematology and cellular pathology will comment on the morphological findings or the cellular findings. Then you have the molecular, then you have the flow cytometry, the immunohistochemical, and you could put it all together and do what's called an integrated report or integrated hematology report, which is the IHR within the blue dotted box on the top left hand side. And that structure sits within what's called the Specialized Integrated Hematopathology Malignancy Diagnostic Service, or SIHMDS. It's quite a mouthful. But when considering the stains, it's always useful to look at how we got there or what's the history behind it. And blood has almost a 400 plus years history when the first blood cells were discovered. After the microscope was discovered, then we got to the white blood cells, and then the concept of leukemia arose. Within the white blood cells, we started describing granular white blood cells and non-granular ones. So it was very clear when you're looking down the microscope, you have either granules in the white cells or they are agranular. And that's what was picked up almost 150 years ago. One of the people who discovered it was recommended for a professorship by none other than Virchow. And this is the letter which is still held in the Library of Edinburgh. There were many illustrations which were published during the time, but these were all kind of black and white or sketches. And then we got to the point where special dyes were beginning to be used besides the H&E to highlight the different textures and qualities. And Ehrlich, whose name is associated with staining in hematology, is thought to be the pioneer. He was quite interesting history. He had medical training and also had an interest in chemistry and dyes, and he had a very profound knowledge of them, and he used them to start staining vital stuff. But then it was Romanovsky who described how the Romanovsky method is how you use methylene blue, which is oxidized along with eosin, to highlight the different textural sort of cytological tinctorial hues within the cytoplasm of hematological cells. And that's a method which has stood the test of time, and we still use it currently, and is probably one of the best stains for hematologists because it allows us not only to look at the nuclear detail, but also to look at the cytological detail, which is quite important. I mean, a lot of criteria on maturation of neutrophils, on maturation of red blood cells are all based on this staining method. Obviously, the different types of stains that have come out of it are the Giemsa, the Wright or Wrighton Giemsa, the May Groundball or the MGG stains, and the Leishman stain. So if you come across any of these, the parent stain is the Romanovsky method. So this eventually then highlights how our understanding of leukemia and bone marrow disorders, or malignancies rather, came across. It's almost a sketch of the history of classification. So leukemia was just an increase in white blood cells, which was the term that Virchow used in the 1840s. And then not much progress was made besides calling it, different types based on some basic concepts of cells, but not really coming to a classification till we get to 1974, where the FAB classification comes out. And this is the original paper that was published. Daniel Kotowski, who's the second author on here, is based at the Royal Marsden. And there were contributions from globally, as the name suggests. And they came up with this classification, which was based mainly on cytological features, but also for the first time, cytochemical stains were recommended. So this is where the importance of cytochemical stains was first highlighted in a published classification. And you can see that in the lymphoid cells L1, L2, and L3, the leukemias, the lymphoblastic leukemias, were classified based on the morphology of the cells, L3 being large and Burkitt-like cells. And then you have the myeloid, undifferentiated to differentiated M1, M2, and M3. And you have the monocytic monoblastic leukemias, and then obviously erythroleukemia, which is M6, and megakaryocytic leukemia, which is M7. It's hidden behind. And here you can see on this picture, on the third column from the top, the third row, you can see that there's some blackish granular staining, and this is the esterase staining or non-specific esterase, which comes up in monocytes. And it highlighted the use of a cytochemical stain in the classification. And in fact, this is the paragraph which covers the cytochemical tests of diagnostic value in leukemias. And the only two stains they mention are the myeloperoxidase and the NASDA, or the naphthol acetate esterase reaction for monocytic leukemias. They also talked about some other stains which were recommendations, like the PAS stain, acid phosphatase, lysozyme, and some lymphocyte markers, but not mentioned which ones. And it's another 20 years, 2 decades before we get to a proper usage pattern of these stains, because it takes time to refine and learn about any new technology which comes out. If you look at the journey of immunostains and currently next generation sequencing, it's exactly the same journey. You start collecting data, you have more experience with different cell types, different diseases in different institutions, and then you get to a proper standardized, approach. And there's that paper from 1985 which recommends cytological procedures in hematology and has a whole list of cytochemical stains in there and how to do them. What basically is a cytochemical stain? It's a reaction between a chemical dye and the cellular constituents. Now, they can be divided broadly into enzymatic and non-enzymatic reactions. The enzymatic ones are mainly the peroxidases, which is the breakdown of hydrogen peroxidase, which gives coloration using a coloring agent like DAB, and comes up usually with a brownish color. Then you have the esterases, which are divided into non-specific and specific ones. The specific ones are targeted against the primary and secondary granules in the granulocytes and mast cells. So CAE, or chloroacetate esterase, is that one. The non-specific is divided on the basis of the short chain of the carbon atom that's there, so butyrate or acetate. And the butyrate esterase, or NSE for short, is the non-specific esterase, and that's useful in monocytic leukemias. Then you come to the phosphatases, alkaline phosphatase, especially treatment with tartarase resistance. Alkaline phosphatase is useful in hairy cell leukemia, the stain we commonly call TRAP. And you have acid phosphatases, which are used in lymphoblastic leukemias. And then the non-enzymatic is a broad category which contains mainly 4 or 5 stains, of which Sudan black is used for myeloid malignancies like the myeloperoxidase. You have the toluidine blue, which is used mainly for mast cells and basophils. And we use the PAS stain for lymphoid cells, especially in acute lymphoblastic lymphomas in leukemias. And then pearl stain for iron. So what does the myeloperoxidase? It's present in the granules, as I described, and this is what it looks like. You get a brownish hue. These are some of the images from the paper that I showed you before, 1985. The International Committee for Standardization in Haematology published the standard methods for doing this, and you can find further details of these tests and also images of what the result should look like, almost like a control. It's red-brown staining. It can highlight the oil rods. It can highlight the granules. Sometimes RBCs stain diffusely brown because of the hemoglobin content. Depends on the lab. You will get some variation in the tinctorial quality in different labs. Eosinophilic granules also stain strongly and are cyanide resistant. Lymphoid cells are negative. Basophils may or may not be positive depending on what sort of coloring agent you're looking at. And Sudan black is a lipophilic dye which sticks to lipids and intracellular phospholipids. The reaction pattern is black, again granular, and can stain oil rods. Rarely lymphoblastic leukemias besides myeloid can be positive, so you have to be cautious about that pitfall. The next one is the phosphatase reaction, which the most common one and more clinically used for a long time is the neutrophil alkaline phosphatase, which is NAP, but is also more commonly called the LAP or the leukocyte alkaline phosphatase. And this reaction stains mature neutrophils and immature precursors, metamyelocyte onwards. And the scoring procedures and interpretation range from a score of 0 to 4 depending on the intensity of the staining. And you count 100 neutrophils and sum the scoring up. The scoring obviously then ranges from about 30 to 130 based on the intensity. And the intensity then describes what the condition could be. So the lab score is decreased in chronic myeloid leukemia because there's obviously a neoplastic population there, whereas it's increased in leukemoid reaction, which used to be a very important distinguishing point diagnostically previously, but I think it comes together with the clinical history and the whole proper context. You can see the list of other causes where they increased or decreased the lab score. And the acid phosphatases, as I was talking about, you can see it in acute lymphoblastic leukemias, which is on the extreme right-hand side with the pink granules, or you could see it in hairy cell leukemia when you treat it with, the tartrase resistant acid phosphatase trap. And that's on that yellowish image on the left-hand side, bottom left-hand side is a hairy cell leukemia. Then we come to the esterases. As I was talking about, they're divided into specific and non-specific. The specific ones are for granulocytes, mature granulocytes rather, and the non-specific is for the monocytes and macrophages. So this is a table. So how do we use these stains? And this is taken from Dr. Catherine Foucault's book from the American Society for Clinical Pathology. They published the first edition about 20 plus years ago. And you can see that the whole long list, that's the table that I've made on this slide, is from the first edition. And by the time the book got to its fourth edition, which came out last year, there were only 2 cytochemical stains which are included, which are highlighted in red. And that's why the 4th edition is highlighted in red on the bottom of the slide. So in practice, the use of these cytochemical stains is decreased. There are various reasons for it, which we'll talk about later. But this is a table which gives you the basic outline. What do we normally use it for in cytochemical or liquid, what we call liquid samples? So when a bone marrow trephine biopsy is done, you have the aspirate and the actual bone biopsy. Practice in the UK differs in that some centers you will have both the aspirate and the trephine being reported by the hematologist, or in some centers the hematologists report only the aspirate and the flow cytometry, and the histopathologist like me would report the bone marrow trephine. So depending on what it is, it's eventually married up. But if you're talking about the aspirates, that's where these stains are used, because we normally use immunohistochemical stains on paraffin fixed, formalin fixed, paraffin embedded, FFP blocks of tissue. The basic two stains, as we talked about before, were the category of lineage-specific stains, the myeloperoxidase and Sudan black, which if positive in the majority of cases would denote a myeloid lineage. If they're negative, then you start thinking about lymphoid or monocytic, and depending on the intensity of the stain. But if you can do a non-specific esterase, then you start seeing the monocytic lineage being highlighted. And obviously for the lymphoid, the ALLs, remember there's the PAS or periodic acid Schiff reaction, which gives a nice pink color because of the glycogen in the cytoplasm. Sometimes you can combine some stains, and here you can see the specific and non-specific esterase being highlighted, and this identifies both the monocytic and the granulocytic component. And sometimes if there's a mixed myelomonocytic population, it'd be useful to highlight that. These are the others. So on the left hand side is a PAS stain in a case of acute lymphoblastic leukemia, which has got nice pink granules around the thin rim of cytoplasm, which is present in these neoplastic blasts. You can use staining, PAS staining in erythroid precursors, and it shows discrete granules towards the immature precursors. So you can see it in sort of late normoblast onwards. Coming back, so the cytochemicals are useful, but the majority of times you should be able to get to a diagnosis based on a sensible approach, looking at the clinical history, the counts, looking at the morphology using the Romanovsky method, any of the stains, the right, depending on what your lab does. There is some minor variation, but one of the Romanovsky stains is used to examine the blood film. We have learned a lot from electron microscopy in terms of what we can see or expect to see in cells, but we don't use it routinely now. The only thing we use is just the routine stain. And we don't really use any cytochemical stains, because by the time you've got an aspirate, you've also got the flow cytometry, and the trephine follows if anything's missed. And these are just basic highlights of what you expect to see based on the morphology and how you classify it. And you can see the nice characteristic cytoplasmic vacuolation within Burkitt-like cells in LD. And then the PAS stain. Obviously, these cells will be negative for myeloperoxidase. If they're lymphoid, they will be negative for non-specific esterase usually. Then one of the other stains, non-enzymatic, is toluidine blue, which highlights basophils and mast cells. In this particular photograph, this is from a chronic myeloid leukemia patient, and you can see intense blue staining, blue to purplish blue, in an increased number of basophils that are seen in this disease, in this particular patient. But workup of mast cells, increased mast cells, the first port of call if there's anything which worries. I mean, by the time you get the clinical, you should be able to have a working diagnosis or a differential diagnosis which includes mast cells. If not, then it depends on from lab to lab. Some labs might do a toluidine blue if they're even slightly suspicious. Others might hold on for a bit and see once they've got more clinical evidence. But depending on whatever the scenario is, you will get the staining in the mast cells. And then obviously it's confirmed on the H&E as these, if you look at the right hand side, on the bottom right hand side, you see these characteristic pink cells with central or paracentral nucleus, which is very regular. And it almost looks like a fried egg. The yellow, instead of the yellow, there's the blue, and then you've got the white around it. This is what it looks like at higher power. You can see the granules in the mast cells on any of the Romanovsky stains. You can also do the toluidine blue to highlight these granules. And then obviously on the H&E, on the bone marrow trephine, you might see shape abnormalities like spindle-shaped cells, which are seen on the screen here. What I wanted to highlight with this image is, if you notice, there is an increase in eosinophils, and there are disorders where you get not just isolated systemic mastocytosis, but platelet-derived growth factor receptor beta associated disorders, or c-KIT associated disorders, and combined molecular pathogenesis, where you might expect an expansion of both mast cells and eosinophils. So depending on what the clinical scenario is, you have to work up your patient, and cytochemical stains are just one step in that workup. What I will want to highlight throughout this talk is it is an integrated report. It is multiple modalities, including histology, cytology, special stains, immunostains, flow cytometry, molecular testing that gets us to a final diagnosis these days. And that's based on the current WHO classification, which we follow internationally. So this is another case where you've got increased erythroid cells, and within the erythroid cells, there's abnormal morphology. If you do an iron stain, which is this particular one, a pearl stain, on the top right-hand side, the image that you see is iron staining within the erythroid cells, and they form granules around that. So this is what you see in refractory anemia with ring sideroblasts, and you obviously have to correlate it with the overall clinical appearance, the history, the blood counts, the molecular findings, and the morphology. Now, in what was the new WHO classification, there are definitions which include molecular, which you can see on this page. The third bullet point is an SF3B1 mutation, and exclusion criteria where you've not got any other coexisting disease in terms of counts or cytogenetic abnormalities. So after all of this, the main challenge with stains or any particular single modality is that disease doesn't follow that. You might have a combination of you might have a biphenotypic leukemia or mixed phenotypic leukemia, where you may or may not have the characteristic pattern, even though these are few and far between, but you just have to be aware of the limitations. Is your lab performing consistently in terms of the stains? Do you participate in an external quality assurance scheme for that, so that the stain that you're doing is meant to be showing what the textbook says? Then you have to be aware of the classification. The classification changes. Instead of cytochemistry, it's now more focused on molecular findings. So even if we do cytochemistry, it may refine treatment. It may, stop the patients receiving molecular therapy, which are options these days. Depending on the clinical setting, there might be a problem with doing expensive tests. And if you are doing cytochemical tests, just know what is the basis of the test, what part of the cell does it stain, what is a positive reaction, is it brown, is it black, and then what does it mean in terms of the interpretation. So a systematic approach is what's needed, because even if you have the most sophisticated tools, you should know how to use them. And then when we're talking about being systematic, I think the backbone of all hematology practice is still the Romanovsky stain. We look at the morphology. In the majority of cases, you will be able to distinguish based on the sensible clinical history, counts, and the aspirate. You should get to at least a differential diagnosis, and then you can think about what kind of testing you recommend. If we are systematic, if we have definitions which are agreed, and we look at cells individually, then we can start to make out the difference, and we don't really need much else. But there are circumstances where you might need them, and therefore it's important to understand what cytochemical stain or immunohistochemical stain to use. I hope this has helped understand how cytochemical stains are used, what are their advantages and disadvantages, and how they feature in the WHO classification. Thank you very much for listening.